Dr. Todd Korthes is a professor of medicine at Oregon Health and Science University, addiction medicine section chief, and addiction medicine fellowship program director. He graduated from the University of Health Sciences at Chicago Medical School in 1991, primary care internal medicine residency and chief residency at Yale University in 1999, and a Health Services Research Fellowship and Master of Public Health at University of California, Los Angeles in 2002. He began his career caring for patients living with HIV and substance use disorders. His research focuses on the integration of pharmacotherapy for substance use disorder treatment in diverse healthcare settings, including primary care, HIV clinic, and rural settings. He serves as principal investigator for several multi-site NIH-funded clinical trials. Please welcome Dr. Todd Korthes.
Hi, everyone. Thank you so much for coming today. And I'm super excited to share what we're doing in the Oregon Hope Initiative around tele-Hep C treatment facilitated by our Oregon Hope peers. And by way of background, we know that injection drug use has led to disturbing increases in infectious disease, including hepatitis C, and that this has particularly affected some of our rural communities where hepatitis C treatment access can be a challenge. We conducted a pilot study in rural Oregon that demonstrated 53% of the people who used drugs who enrolled were positive for hepatitis C antibody, but only 4% reported access to hepatitis C treatment. They identified stigma and transportation barriers as things that limited their access to healthcare in general and hepatitis C treatment in specific. That we also conducted during that time a pilot peer engagement intervention that demonstrated high comfort levels of people who use drugs when they were interacting with peer recovery support specialists, people who have at least 2 years of recovery and deep lived experience with the same issues that people are facing. And so we used all of this to develop a telemedicine Hep C treatment intervention that was facilitated by peer specialists. Here are our Oregon Hope partners around the state. The study randomizes people who use drugs in rural Oregon communities to one of two conditions. They receive either peer-facilitated telemedicine hepatitis C treatment or peer-facilitated referral to local community providers for hepatitis C treatment or enhanced usual care. We included anyone who reported any amount of injection drug use or recreational opioid use that was non-injection in the past 90 days, had a positive hepatitis C viral load PCR and health insurance eligibility, which was predominantly Medicaid. We excluded people with decompensated cirrhosis, pregnancy, or breastfeeding. We collect surveys at 5 time points over the course of several months and blood draws at 3 time points at baseline, end of treatment, and 12 weeks after treatment. We're also conducting some qualitative interviews of people's experience. The primary outcome for the study is sustained hepatitis C virologic response at 12 weeks after completing treatment, or SVR12. And this is the definition of cure from hepatitis C. The secondary outcomes we're looking at are treatment initiation and completion, engagement with harm reduction and substance use disorder treatment services, and substance use to see what effect it has on those factors as well. The peers are really the glue to this intervention, as they are in most things. The peers directly support the study participants with confirmatory testing. They assist the participants in enrolling in OHP and health insurance. They help them navigate to confirmatory hepatitis C labs and pretreatment labs. And then those who are eligible, they randomize to one of the two conditions. Everyone gets an initial warm peer facilitated handoff. In enhanced usual care, the peers connect the participant to the CCO care coordinator for hepatitis C and provide direct referrals to local community providers for treatment. In the Telehep C arm, the peers schedule and actually initiate the Telehep C treatment appointments with the study telehepatitis C treatment provider at OHSU. In the Telehep C group, the Telehep C provider prescribes medications for treatment of hepatitis C and sends the prescription to a specialty pharmacy, coordinating with the peers to get that prescription mailed to the patient. Peers then spend the rest of treatment facilitating the patients taking these medications. They assist them in picking up the medications from a pharmacy if that's the case, or from the mail order. They encourage treatment adherence. They support other needs as well. For example, linkage to substance use treatment and harm reduction supplies. They also help contact the participants for the 4-week visit and the SVR12 labs and other study time points. And here are our very early implementation results so far. We've definitely been slowed in recruitment, which opened in July 2020 due to the COVID pandemic, with 28 people enrolled so far in one county. 85% of the people, however, who have been randomized to peer-facilitated Telehep C treatment have actually initiated Hep C treatment within 2 to 6 weeks after randomization, whereas only 1% or 7% of those randomized to enhanced usual care have initiated treatment. So this raises a couple of points of innovation. First of all, this approach is reducing many of the technological barriers to telemedicine. The peers are actively facilitating tablet and Wi-Fi access for clinical visits as needed. They connect clients to additional resources, for example, cell phones or smartphones and phone minutes. They facilitate the follow-up visits, contacting friends, family, or the peers themselves to reach participants who are unavailable. A second innovation is that we're reducing other important barriers to Hep C treatment. For example, barriers that are related to housing. The peers and the study team have developed a protocol for storing hepatitis C medications, for example, in lockers at a community-based organization for those who are not able to have a mailing address or have unstable housing. We've also reduced the points of drop-off from Telehep C treatment by creating standing lab order forms for immediate lab visits to eliminate a pre-treatment clinician visit step. We've also created an infrastructure for treating patients with very, very little notice. And then currently in progress is a validation study of a dried blood spot technology where peers just collect a finger stick of blood drops on filter paper and then mail that to the lab for pre-treatment lab testing, which is a remarkable improvement. The study has not been without its challenges. The first one has been incomplete or difficult blood draws, as well as experiences of stigma in the process of going to hospital labs. And so we've offered training and education to the lab phlebotomy staff. We have had the peers advocate for the patient. So they physically accompany the patient to the lab and advocate to the phlebotomist, and then model just respect and warmth and make sure that the patient critically is well hydrated and warmed to ease phlebotomy. In one case, we had to shift to a lab who was extra responsive to the needs of these patients. Another challenge has been scheduling. Anytime you're interacting with the healthcare system, things are complicated, right? And our hospital provider scheduling template was a little bit inflexible. And so we met with the hospital administrators who allowed providers to schedule their own appointments in Epic, and then empowered the peers to directly contact the providers for scheduling purposes, and reduce the number of handoffs in that process. That's dramatically streamlined things. And then another challenge has been staying in contact with the patients. We have lost contact with a few. The biggest challenge seems to be retaining and charging cell phones. And so the peers have been exploring other resources to support cell phone access and conducting outreach with people. This is an ongoing issue that we're continuing to try and address. And then finally, there have been a few clinical concerns. For example, these are patients who are completely outside of the healthcare system by and large. Some of them have serious mental health issues. So in one case, for example, there was an adherence issue due to psychosis. Another one had very low albumin that was likely attributed to malnutrition. And so the clinician treating the telehealth Hep C also was able to prescribe some mental health medications as needed at the initial visit, and the peers have been assisting with food assistance as well. So far where we're at with the study is, I think we can conclude that first of all, the public health response to the opioid and substance use and overdose crises must adapt to address the healthcare priorities of people who use drugs, including for hepatitis C treatment. This whole initiative grew out of our initial conversations with people who said, yeah, we're a little bit interested in treatment and harm reduction supplies, but what we really want is hepatitis C treatment. And listening to that voice, I think, is our North Star for guiding public health responses. The second major conclusion is that, again, this is very preliminary data, but peer-facilitated telehep C treatment may be able to advance the WHO 2030 hepatitis C elimination goals in rural communities by expanding hepatitis treatment access directly to people who use drugs. And so far, our very preliminary experience suggests that, in fact, this is definitely expanding access, and people are definitely initiating treatment. Thank you very much.